do that yet until tomorrow. So we're sure not going to get through all these questions. I just thought I have extra ones here. I'll just give you all of them, and then we'll see what some works. And I saw right off the bat, I tried to change one to a physician assistant, and then down in the question, we suddenly turned into a dental student. Okay, so you will see questions like this where here we have a spirogram. Here we have a spirogram. We're looking at the volumes of gases moving in and out of the lung as somebody is breathing, and then when they're doing different type of inspiratory and expiratory efforts. And this first one, alveolar pressure is 0 centimeters of water pressure at point. So before we even look at that, anytime when air is not moving, right there would be 0. Air is not moving. Air is not moving. Anytime air is not moving, that tells you something. It means that your alveolar pressure is equilibrated to atmospheric pressure, and when you're talking about ventilatory mechanics, you take atmospheric pressure as 0 centimeters of water pressure. So anytime air is not moving, you know alveolar pressure is 0. So let's look at point A. Point A is, that's at the end of a tidal breath. Stand here with my mouth open. A, alveolar pressure would be 0 at A. You go to F. When you take a deep breath, at that point where you stop, before you relax and let it out, air has stopped moving. So that tells you alveolar pressure is also 0 at F. Okay? At M, going from L to M, what would you call that type of movement, going from L to M? Forced expiration. And they stop at some point. If air is not moving, I'm at 0. So D is the correct response. All the above are correct.
So M, it doesn't matter anywhere that it's on the bottom of that curve, because that's the only thing that got me is that it was shifted to the right a little bit on the bottom.
When you get to a stop point where you're reversing from inspiration to expiration, there is a point when it's at 0. Now, if I would, from L to M, if I would have drawn a dot someplace between L to M, then it wouldn't have been 0. Then it wouldn't have been 0. But any of those, when you just relax, like right here, what's the volume of gas in my, what is the amount of gas in my lungs when I just relax? Functional residual capacity, FRC, that's at 0. So any M plus F, any of those transition modes. So, and there's a lot of different, let's go through these first 6 questions, and then I'll maybe throw some other things in here just to help you think some of these through. Because you'll always have a spirogram on my one and only exam coming up with you with this. You will have a spirogram. And I'll be asking you what's going on with volumes and pressures and different things. So this next one, number 2, is resistance to airflow. Anybody remember, and boy oh boy, if you don't write it out, if you don't draw it out, if you don't talk it out, you haven't learned it. So right off the bat, I would, when I see resistance and we're talking about airflow, I would have off to the side drawn this type of graph. That, let's say that is residual volume, and this is total lung capacity, and this is air flow resistance. What does that graph look like? what this is telling me is when you get to higher and higher lung volumes, you have lower and lower resistance to airflow. Okay? And, you know, before I even go on, why is that? Let me, now I'm not drawing a flower here, but let's say we're looking down a small airway and here are alveoli lining that airway. If you take a deep breath, what's going to happen to those alveoli? They expand outward, don't they? What happens to that airway? It gets pulled outward. So as those alveoli are expanding, they're pulling the airway open. And these septal walls right here, when they pull, that's called radial traction. Radial means to the outside, traction means pulling. So you're pulling these airways outward. So that's what's, when you're at RV, you're in this situation. When you're at TLC, you're at that situation right there. And here we have tubes. Air is a fluid. And what is the relationship between resistance to flow and the radius of a tube? 1 over r to the 4th, exactly. And that is the reason why this curve looks the way it does. Okay? So, resistance to airflow is at its greatest. So, when is resistance at its greatest? Someplace along here on this curve, right? So let's try to find where that might be from these choices. So resistance to airflow at A, okay, A, you're not really at a very low volume, are you? You're really at F or C. At F, you're at an elevated lung volume. At M, okay, you're at a lower lung volume there, so resistance could be fairly high. At Y, oh, you're probably very close to total lung capacity if you aren't already at low total lung capacity. Z is the lowest volume that I see on that graph, so E looks to be the correct response to me. Okay? Now, I can ask these questions so many different ways. I don't even have to bring this, you know. Looking at, I can ask the question, for example, where would, so radial traction is the pulling of the airway open. Where on this graph would radial traction be the greatest? Why? I totally agree. Totally agree. So, if you can put this together and understand that relationship, and you know that, okay, what we're looking here are lung volumes, and this is a lung volume, residual volume, that's total lung capacity. Ooh, you have a lot of information right there. And you can say a lot of different things about that. Everybody kind of comfortable with that? Okay. Which segments would require activation of the ventral respiratory group? Okay, so if we're just taking a nice, quiet inspiratory effort, are we activating the ventral respiratory group? It's just the dorsal respiratory group. We activate the ventral respiratory group when we make a deeper inspiratory effort, and also anytime we do a forced expiration. Okay, so which segments would require activation of the ventral respiratory group? Right off the bat, I think, okay, anytime we're going to do a forced expiration, and anytime we take a deep inspiratory effort, okay? So, let's see, going from E to F. That looks like somebody's taking a deep breath, right? I think if you're taking a deep breath, you're probably activating your accessory muscles for inspiration. So yes, and it's your ventral respiratory group will drive your accessory muscles for inspiration, among other things. So I think, yeah, B to F, you're definitely activating your ventral respiratory group. Going from L, where's L? L to M. You already told me that that's an expiration, that's a forced expiration. I think somebody said that earlier. So guess what? Right there, that's activating the ventral respiratory group. Going from Y to Z. Now, you know what? Here's kind of a tip. When we're up at Y, all we have to do is just relax, and we're going to come down to FRC. But this person, they went up to Y, and they probably had somebody telling them, blow, 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 go, 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 all the way, all the way. They had Dana yelling at them. Exhale as fast and as hard as they can. So I think you're activating, well, I know you're activating the ventral respiratory group there. So I'm going with choice D. Yes?
So just to clarify, so the ventral respiratory group is activated when you have like forced expiration and also a very deep inspiration?
Exactly, exactly. So when we're just doing tidal breathing, it's dorsal respiratory group, and then what about tidal expiration? You just relax.
What about F to G? Just going, so you're at the top of it, going F to G?
Okay, if we are up at, let's say we go to total lung capacity,
Yeah.
and we just relax down to FRC,
Nada.
nothing. It's totally passive.
Good.
It's totally passive.
All right.
It's totally passive. But if Dana is yelling at you, blow, 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 all the way, go, 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 go. And you know, you really have to be absolutely on your toes with your respiratory tech to get the maximum effort from the patient. You are in a forced expiration all the way down, actually.
So even if you went like, I don't know, if you went lower than this, so you had to go like this.
Lower than
would
which
you
one?
Still, like, if you just had a little curve,
Okay.
like it's a deep breath, but not like a super forced inspiration, would you still use your ventral group?
You know, I can't really tell you on there where the ventral kicks in.
Okay.
But I do know if you take a much deeper breath, I know for a fact it's activated.
Okay, so anytime you're gonna have like
Yeah.
there's not like
Do
in and
you
out,
see,
we're
do you
gonna
see
say-
these just normal tidal
Mhm.
inspiratory breaths?
If it goes above there, we're saying it's activated?
I would,
Okay.
I would.
Okay.
Now, I'm not gonna try to make it split hairs and have it just a little bit higher, but I want you to know with normal tidal breathing, it's just your dorsal respiratory group, okay? And so, yeah, I think that kind of covers what I want to hit there. So, at which point is intrapleural pressure the most negative? Now, remember, if we look at our lung in a bottle type diagrams, when we are at rest, and intrapleural pressure is different at the top of the lung versus at the bottom of the, well, I shouldn't say at the top of the thoracic cavity and what's at the bottom of the thoracic cavity. I'm just saying that's an average right there. But when you make an inspiratory effort, does this intrapleural pressure become less negative or more negative? It becomes more negative. For example, with tidal breathing, let's say that becomes a -8, that will pull those walls outward. If we're going to take a very deep inspiratory effort, let's say going to Y, what's this number going to become? Even more negative. You know, actually, if you go to total lung capacity, you're probably up to like -20, -25. Very, very low. But the lower you make your intrapleural pressure. So, and oh, I should ask you, how do you make a low intrapleural pressure? A low intrapleural pressure is due to increasing your thoracic cavity volume. Increase in volume, decrease in pressure, right? So, diaphragm contracting maximally, driving the diaphragm downward. Your external intercostals lifting the rib cage upward and outward. Plus, if you're doing a maximum inspiratory effort, you think about this. You grab a hold of your sternocleidomastoideus and you take a deep breath as deep as you can. When you get right up near the top, you feel that thing contracting. If you palpate real deeply, and I don't suggest everybody do this, but you do the same thing, so where you're getting close to your scalenus muscles, whoop, they pop up. So, and same things happen with your pec minor. If somebody's palpating your pec minor, they're a very intimate friend. And I'm not even sure if you can get quite there. So those accessory muscles are raising the rib cage even higher. So at which point is intrapleural pressure the most negative? And that would be Y. On here, where would the intrapleural pressure be the most positive? Z. Yep. At Z. Now I could do the inverse with that number 4. I could say, at which point is the thoracic cavity volume the greatest? It would still be Y. Everybody kind of okay with that? Okay. These spirograms, you really do, you can cover a lot of ventilatory mechanics here. Okay. If point Y represents a person's total lung capacity, okay, and point Z represents residual volume, what is her expiratory reserve volume? Oh, okay. So what is expiratory reserve volume? Well, at this point, let's take a look at the total volume of gases, total amount, excuse me, of gases in your lung. When you're just relaxed, there is a certain amount of gas in your lungs called your FRC, your functional residual capacity. Now, this woman, she was all the way up to TLC-Y, and she exhaled, she's past FRC, and you can't exhale out all the gas in your lung, can you? You can only exhale down to this point. The amount of gas that is in your lung that you cannot voluntarily exhale out is your residual volume. But here at FRC, hey, you have a volume of gas that you can exhale out if you want to. That's your expiratory reserve volume. So, her expiratory reserve volume would be from FRC, and it looks to me like FRC is falling right at 3 liters. And she's exhaling down as forcefully and as far as she can to get to Z. And if I look at that graph right, that looks to me to be, she's at the 1.5, her residual volume is 1.5 liters in this case. So her expiratory reserve volume is 1.5 liters. What's her FRC? 3. What's her vital capacity? What was her total lung capacity? Tell me what in liters her total lung capacity is. It's 6. Let's say it's 6. So it's 6,000 mils. What is vital capacity? It's the amount of gas you can voluntarily move. The maximum amount of gas you can voluntarily move. So take as deep breath as possible and blow all the way down to residual volume. That's vital capacity. So vital capacity for this woman would be 6,000 mils minus what she can exhale out, her vital capacity is 4,500. So how you doing on this? You know, once you see these things once, then it's all kind of simple. Okay, so for the person above, moving from FRC to TLC results in which of the following? So that is going to be a maximum inspiratory effort. Kind of what I drew here, okay? Maximum inspiratory effort. So, when you are at FRC, what's your alveolar pressure? 0. Right, say that was in comments. 0. So it's at 0, and something happened. So alveolar pressure is initially positive. It was initially 0. So A and B right off the bat don't look right, because when you're talking about initial alveolar pressure at FRC, it's 0. So right off the bat, A and B don't look right to me. But let's look at C. Going from FRC to TLC, activation of the ventral respiratory center is not required. Yes, it is, to activate those accessory muscles of inspiration. D&E better come home for us, okay? Alveolar pressure begins at 0. Yeah, alveolar pressure is 0 at FRC. We make an inspiratory effort, it becomes positive and then returns to 0. It becomes negative, doesn't it? And if you're making a maximum inspiratory effort, it might be, very, quite negative. -8. As soon as that becomes negative, air starts coming in. And once air has filled this expanded space, it's going to go from 0 to -8, and then more air is going to come in, but it's going to come in more slowly. It'll be a -6, then a -2. When we're all the way up to TLC, it's back to 0. I can tell because air stopped moving. So, E's looking good to me. It became negative, and it went to 0. Okay? So, I think without much trouble, you can imagine me writing pretty much inverse questions to all of those to see if you kind of understand the concepts. Maybe you would throw a different word in there. Anything about these type of ventilatory mechanics you want to talk about? Okay. So, 7's kind of a knowledge question, I think. Which of the following is true regarding pulmonary surfactant? This is really a picky question. I probably wouldn't ask this of you, but there's still information to learn. You haven't had histology. At least you guys, you don't have histology as a prerequisite. So, but you can still learn things from it. So which of the following is true? Underline true. It's an automatic qualifier. A pulmonary surfactant, another automatic qualifier. Okay. Okay, pulmonary surfactant does not become fully functional until the 4th month of gestational development. It just starts being developed at the 4th month. It just starts becoming functional at the 7th, and you don't yet have near enough of it even at the 7th. So A is wrong. A is wrong. B, pulmonary surfactant increases the surface tension of water that lines alveoli. It decreases surface tension. If it decreases surface tension, what does that do to elastic recoil? It decreases elastic recoil. What does pulmonary surfactant, if you have a decrease in elastic recoil, what's happened to pulmonary compliance? There's an increase in pulmonary compliance. Oops, I see some of those are coming up. Okay, that's fine. C, premature infants suffer respiratory distress. That's true because of too much pulmonary surfactant. It's too little functional pulmonary surfactant. D, pulmonary surfactant decreases pulmonary elastic recoil and increases pulmonary compliance. Okay, so surface tension, elastic recoil, pulmonary compliance, they're all interrelated, and I want you to understand that relationship. And then this is E. I wouldn't hit you with E. It is a complex substance composed of lipid and protein. I expect you to know that. And it's synthesized by type 2, not type 1 alveolar cells. I know I gave you a slide that talked about that has type 2 on there, but since you haven't had, that was just one little place in the slide. I wouldn't put that in there. So D is the correct response. D is the correct response. Now, before we leave this, there's two primary components that play a role in regulating elastic recoil and pulmonary compliance. Surface tension is one of them. What's the other component? Connective tissue. Yeah, connective tissue. So pulmonary surfactant, that is associated with surface tension effects. And it's not just premature infants that premature infants don't have enough functional pulmonary surfactant, but there's many, many, many different things that can happen in adults. Trauma of a car accident where you have broken bones and bruisings and damage throughout the body. For whatever reason, it can lead to a dysregulation of pulmonary compliance. There's not enough functional pulmonary compliance and lungs can get stiff. Smoke inhalation, drowning, all sorts of different things can cause the loss of pulmonary surfactant, leading to adult respiratory distress syndrome. In kids, it's infant respiratory distress syndrome. But in adults, there's diseases, there's trauma, there's so many different things that can cause, at least transiently, the loss of functional pulmonary surfactant. And people can get stiff lungs, increases the work of breathing, and in addition to the other problems they have, now they have problems ventilating. So the work of breathing is increased for people with emphysema. Think so? Yeah, it's easy for them to get air into the lung, but they have poor elastic recoil. And so air flowing out isn't all that great. You can get airway collapse due to dynamic compression of airways, which we really didn't talk about. So yeah, people with emphysema, they do have an increased work of breathing cost. Restrictive lung disease. What's restrictive lung disease? That's a deficiency of lung inflation. It's hard to inflate the lungs. That can come from infant respiratory distress syndrome. That would be a restrictive lung disease. Chronic bronchitis. It's chronic bronchitis. Too much mucus in the airways. So what is when you're given a case scenario, and I think I mentioned this to you, I don't care if it's for dental students, medical students, I've seen it for pharmacy students, haven't seen your national board exam, a real live national board exam, but the kicker, you hear about a productive cough. A productive cough means somebody is hacking mucus. If you hear about a dry cough, there's probably not much mucus causing that cough. There's an irritation. But a productive cough, somebody is moving mucus, and you might have some bronchitis going on there. So D is the correct response there. And Dana, feel free to correct me when I'm wrong. But when you hear about a hacking cough, it tells you something right off the bat, and it tells you mucus. And I'm a fan of mucus, don't get me wrong. There's a lot of good things for us. Okay, so a patient who is suffering from pulmonary fibrosis. So the simplest way that I draw pulmonary fibrosis, and it is an oversimplification, but it does at least allow you to visualize something. There is an inappropriate elaboration of connective tissue in the small airways and in your alveoli. So there's an increase in the connective tissue component, and that connective tissue is relatively incompliant. So a patient who is suffering pulmonary fibrosis is most likely to display which of the following changes in total lung capacity, compliance, diffusion capacity, and elastic recoil. So, the first column here, let's just kind of go through the first column, total lung capacity. Somebody with restrictive lung disease, are they going to find inflation more difficult or more easy? Much more difficult. So their total lung capacity, and of course this is progressive. Somebody with slight restrictive lung disease, there won't be much of a change. Somebody with extreme restrictive lung disease, their total lung capacity will be diminished. So, restrictive lung disease, there is a restriction in lung inflation. So, I'm going to just look at total lung capacity, and I see A, B, and C all show a decrease. So right off the bat, those are the ones I'm playing with, okay? So, a change in pulmonary compliance. So, a person with restrictive lung disease, what is going on with their elastic recoil? Increased elastic recoil, what's their pulmonary compliance? Decreased. And really, what is pulmonary compliance? Compliance, the term compliance means yielding to pressure. So, what is compliance? It's a change in what over a change in what? A change in volume over a given change in pressure. So, with a person with severe restrictive lung disease, when they make a certain intrapleural pressure, that in a healthy person will cause that lung to expand greatly, that same change in pressure does not lead to the same change in volume. It's lower. It's lower. So we're looking for something with A, B, and C where there's a decrease in pulmonary compliance. And that we're down to A and B. We're down to A and B. Now, this next thing is diffusion capacity. You know, diffusion is surface area times diffusivity, and that is lipid solubility over what? Yep, the square root of the molecular weight times the partial pressure gradient in this case, all over the thickness of the barrier for diffusion. What's happened to the thickness of their barrier for diffusion? It's increased. It's increased. So, if the thickness of the barrier for diffusion is increased, what's happened to their diffusion capacity? It's decreased. Very good. B's looking good to me at this point. Elastic recoil, is it increased with them? Yes, it is. So, that's how I do those, kind of one step at a time, work my way left to right. Any questions on that? Okay, we have an 81.5 kilogram man. That's 180 pounds. He's normal body weight, so he's not obese. He's not a 4-foot guy. He's very, very heavy. He's a normal body weight. He has a tidal volume of 600 mils, so every breath, 600 mils is going in and going out. And he takes 10 breaths a minute. Okay. The best estimate of his alveolar ventilation rate. So, he has air, when this supposed to represent the entire lung. When he makes an inspiratory effort, a lot of the air is going to come in here, some of the air remains in the tracheobronchial tree. So it's only the amount of air that makes it to the alveoli, that's what contributes to alveolar ventilation. What's up here, that's called anatomic dead space. So anatomic dead space does not contribute to alveolar ventilation. So this is looking for an estimate. So every time he takes a breath, it's 600 mils. And we want to know, first off, how much is making it to the alveoli with each breath, and not all of it is. So we need to estimate his anatomic dead space. In a normal weight individual, now in a pulmonary function lab, there's easy, quick ways of measuring what this anatomic dead space with the volume is. Very easy to do. But if you have to estimate, somebody's body weight in pounds is really kind of close. So his body weight, this does call for an estimate, is 180. So that means with each tidal breath, about 420 mils of gas is coming in with each breath. Okay? This guy is breathing 10 times a minute, so we're looking for alveolar ventilation rate, so I put a dot, so that means per minute. This person, 420 mils per breath, he is taking 10 breaths per minute. His alveolar ventilation rate is 4,200 mils. So every minute, 4,200 mils of gas makes it to his alveoli. Now, if I would have asked for minute ventilation or minute volume, that's the total. What would his minute ventilation be? 6,000. Because then it's just tidal volume times breathing frequency. Here's where I mixed up this set of questions. So I was going to make a PA student, and suddenly it became a PA dental student. So anyway, maybe they were there together. Okay. A PA student goes on a summer medical mission trip, very high up in Peru, and this is one of the highest permanently populated cities in our hemisphere. City of 30,000 people, high up in the Andes, 16,728 feet above sea level. The student notices a substantial increase in pulmonary ventilation. He's probably breathing faster and even maybe a little more deeply. This results directly from the effect of hypoxia. So this is going to be an increase in ventilation due to hypoxia on are the aortic bodies sensitive to hypoxia? Yeah. Aortic bodies, if there is an elevation in CO2, a drop in pH or a drop in oxygen, any of those will stimulate ventilation. You're going to hate B. B you're just going to absolutely hate. Does hypoxia stimulate the carotid sinus? The carotid sinus is where you have the baroreceptors for the blood pressure regulation. If that said carotid bodies, but that is actually an important distinction in medicine. Carotid bodies and the carotid sinus where you have the baroreceptor, they're close to one another, but they are not the same. They're not the same. So B's not correct. The medullary or central respiratory centers. those chemoreceptors and the other, those central chemoreceptors are insensitive to hypoxia. They're sensitive to hypercapnia. They're sensitive to acidosis, but they are not sensitive at all to changes in oxygen. So A is the only correct response. Now, I intentionally put B, you know, that carotid sinus there at B, because if I would have, because if you knew C was incorrect, you knew it can't be all of the above. So I did try to be a little bit decent about it. Yeah.
So the medullary respiratory center, that's where they're processing the information from the chemoreceptors, but they can't actually.
The respiratory center is where the chemoreceptors are. And they also, so the chemoreceptors and the respiratory centers are right next to one another. They are subjected to the same cerebrospinal fluid.
But they're not, because they all respond to hypoxia, but they
Right.
respond here. Okay.
Exactly. They do not directly respond to hypoxia.
Nope. Yep. That doesn't.
Okay, so in the days following his arrival as the Rhino Canada, okay, which would be expected to be increased in the PA student's urine. Okay, so this person has an increase in ventilation rate. They're hyperventilating, and that is an appropriate response. So they're probably, what's happening to their pH level, do you think? If they're hyperventilating, they're not doing any more physical work, but they are breathing faster. You think their arterial CO2 is going up or going down? Yeah, they're going to have their arterial CO2 going down. They are going to be experiencing a respiratory alkalosis, a respiratory alkalosis. So their kidneys can respond with a maneuver that by itself otherwise would cause a metabolic acidosis. And what's that? Getting rid of bicarb. If the kidneys would just get rid of bicarb from just by itself, you become acidotic. So guess what? This person is suffering of respiratory alkalosis, and if you look at those illustrations we were talking about yesterday, what would be happening is they would not be reabsorbing all of their filtered bicarb. They would be undergoing tubular secretion of bicarbonate. Bottom line, bicarbonate is going to be going into the urine. The pH of the urine is going to increase. So this respiratory change due to altitude, the kidneys would be trying to compensate for that change to help keep pH around that 7.4 range.
So I'm trying to picture that, because that equation, so if they're getting rid of that bicarbonate.
So what's
more CO2
what's
going to be made?
what is? Pardon me?
Did you say more CO2 will be getting made?
No, it's, oops. They're blowing off the CO2, so that equation is going to move from right to left.
Okay.
And when it moves from right to left, you become alkalotic. When it goes from left to right, you become acidotic. So the respiratory system is driving it to the left. And remember, you need 20 bicarbs for every CO2. Now as CO2's low, so you got to get your bicarb lower.
Gotcha.
That's where that comes from.
Okay.
That's where that comes from. Okay. okay, a person has 10 grams of functional hemoglobin. That is kind of the lower limit before you say somebody has anemia. Below 10 grams of functional hemoglobin, you usually say they're anemic. Once again, I'm using the term functional hemoglobin. Some people can have a lot of hemoglobin, but it's dysfunctional. They're anemic. Okay, we have a person with 10 grams of functional hemoglobin for every 100 milliliters of blood, and that hemoglobin is 90% saturated. 90% saturated. So before I even go on, I'm just going to go, okay, they have 10 grams of functional hemoglobin, and I know every gram of, well, let me just put it out this way. I don't want to do a shortcut on you. Every gram of hemoglobin can carry 3.4 grams of oxygen for every 1 gram of hemoglobin, and they have 10 grams of hemoglobin and 100 mils of blood. So this tells me that this person's blood has the capacity of carrying 13.4 milliliters of oxygen for every 100 milliliters of blood. That would be their oxygen carrying capacity. Capacity is as good as it gets. That's the capacity. Now, the other thing that I'm always interested in is what's their actual content. And their content is really capacity times percent saturation. So 90% of their mining sites are saturated with oxygen. So we have 27, there is 10.6. So their content is 10.6 mils of oxygen. I think I calculated that
How come you don't reduce down your fraction to
right. I'm
13.4?
sorry, pardon me?
How come you don't reduce down your fraction? to 13.4?
I didn't carry that. Yeah, holy cow, I didn't carry my,
It's just,
I can't do simple math. It's 12.6. Jeez. I just didn't do the math right. I didn't carry that number. How bad is that? So that's what the content actually is. That's what the content is. Content is never greater than capacity. Capacity is the best it can get. So whenever I look at these, I always calculate it first because I don't want one of these foils to send me the wrong direction. So this person has an oxygen content of 13.4. No, they have a capacity of 13.4. Oxygen is attached to 90% of the heme groups in his blood. Yeah, that's true. That is true. An oxygen carrying capacity is 12.6. 0.6. I really can't do that. And so A and C are really kind of turned around. A and C are turned around. Carbamino compounds are attached to 90% of the globin subunits of his blood. Carbamino compounds would only be maximally attached to how much? 10%. Why? Carbamino compounds is CO2 binding to the globin subunit of deoxyhemoglobin. And only 10% of that person's blood is deoxyhemoglobin. 14, there's a switch finally with kidneys.
did you say
Yes, we have-
B and C were correct?
Pardon me?
Did you say B and C were correct? 13.
No, I'm saying B and C are flipped around from one another.
No, A and C are.
A and C. B is the correct answer. B is the correct answer. D is incorrect because carbamino compounds could only maximally be attached to 10%.
Why is C incorrect?
B.
Carrying capacity, right? 'Cause it's in the-
Oxygen is attached to 90% of the heme subgroups.
That's why Right, okay, I see what you're saying. Gotcha.
Yep. B is the correct response. So 14, the kidneys function to convert vitamin D to its most active form. Yeah, that's true. That is very true. It releases a substance that increases red blood cell production. What's the name of that substance? Erythropoietin. I should say, ask you, what's the most active form of vitamin D? It's 1,25-dihydroxycholecalciferol. The kidneys function to, whoops, I'm blocking that. The kidneys function to regulate extracellular fluid volume and blood pressure. Absolutely, absolutely. So D is the correct response there. D is the correct response. Okay, how many of you have yet, not all of you know that program learning packet on glucose handling and renal clearance where you did the top panel and then you moved? How many of you actually gotten through that? Be honest. Not a one of you. You're honest. You're honest. I like that. I like that. You're going to find out that UV over P is the equation to determine clearance of a substance from the bloodstream. And even without you knowing that, in a normal, healthy person, how much glucose should be in that person's urine? 0. You should have 100%, in a normal, healthy person, 100% of your filtered glucose tubular reabsorbed back into the bloodstream. So, if you have 0 glucose in the urine, clearance of glucose will be 0. It's just that simple. It's just that, even if you haven't looked at that yet. So those questions with, well, there's actually something coming up that even if you haven't seen it, I want to go through those questions just so you can have it read now. So aldosterone differs from atrial natriuretic factor, okay? Tell me something about aldosterone. It's a steroid hormone, okay? Atrial natriuretic factor, what is that? It's a peptide, you're right. Right off the bat, that tells you a lot of things. That right there. So aldosterone differs from atrial natriuretic factor in that it assists in the correction of an elevated extracellular fluid volume. So that means it's evidently taking an elevated back down to normal. Does that sound right? Yes, it will. You're right. Aldosterone does just the opposite of that. It will take a depressed extracellular fluid volume and bring it back up closer to normal. That A is actually what atrial natriuretic factor does. Right? B, aldosterone differs from atrial natriuretic factor in that aldosterone regulates renal sodium reabsorption. They both do. So there's certainly no difference there. It's just that they regulate them in different directions, right? Aldosterone causes tubular reabsorption of sodium, so you don't lose it in the urine. ANF or AMP does just the opposite. It prevents reabsorption, so you have more urinary excretion of sodium. C, aldosterone binds intracellular receptors to exert its actions. That's what steroids do. Where do peptide hormones bind? Membrane surface receptors, right? Very good, very, very good. Okay, 17, this looks like a, okay, and let's just jump to 18. We'll do 17, but we're using different terminology with you guys. A, I should have changed it for you guys to tissue osmotic pressure, and I should have changed D to capillary osmotic pressure. Oncotic and osmotic and colloid osmotic, all those terms mean exactly the same. Oncotic, osmotic, and colloid osmotic, they're all equivalent terms. So, let's look at 17. And before we even get to 17, let's look at W and X. You see the arrows are going in the same direction? So what type of forces are W and X? Filtration forces. And Y and Z are reabsorption forces, that's right. And I'm trying to, okay, so for the capillary depicted above, W and X represent A, filtration forces, done. Okay, 18 for the capillary depicted above, what does Y represent? I'm trying to,
Tissue hydrostatic pressure.
tissue hydrostatic pressure, that's exactly right. Tissue hydrostatic pressure. Let's jump to 18. We're on the shores of the Dead Sea.
So, question, so we skipped 17 and we just did 18?
Pardon me? What?
No, we're
17
moving to
was-
19. 17 was A, 18 was B.
Yeah, 17's A,
And then 18 is D?
18 is B, yeah. Yeah, when I had you tell me what those things represented, we automatically answered A. So we are on the shores of the Dead Sea. It's 13,000 feet below sea level. So, before we even get to it, let me draw one. Here's the nice blue ocean. We're on the shore. Here's a mountain. Here's the, let's say, here's the Dead Sea. The Dead Sea is actually below sea level, a long way. So, for atmospheric, for total barometric pressure, what do you usually consider sea level? 760. 760. And let's say, you wouldn't know this, but let's say we happen to have Mount Everest right on the shoreline here. That would be actually below 250 for total barometric pressure. So looking, here's sea level. Dead Sea right here, it's below. What do you think the barometric pressure would be? Would it be above 760? Would it be below 760? It's quite a bit above. And I made it simple. I just said it's above 800. It's above 800. So therefore, which of the following statements are true? The inspired oxygen would be greater than 150. Now, I told you some numbers to remember. Inspired oxygen, somebody with a barometric pressure of 760, I told you, I want you to remember that barometric pressure for inspired oxygen would be about 150, alveolar oxygen would be about 100. So, if inspired oxygen is about 150 when you are at sea level, what do you think inspired oxygen would be when you're at the Dead Sea? It's going to be above that. It will be above that. Didn't care if somebody calculated it out. You could. It'd just be 800 minus 47, and then that number times 21, and you'd have it. But the partial pressure of inspired oxygen would be greater than 150 torr. That's correct. B, the partial pressure of inspired water would be greater than 47 torr. Doesn't matter where you are, inspired oxygen at 37 degrees is 47 torr. Whether you're at sea level on top of Mount Everest or on the shores of the Dead Sea, it's 47 torr. That doesn't change. Fractional concentration of atmospheric oxygen would be greater than 21%. That also doesn't change. It's 21% of the air when you're at sea level, when you're on top of Mount Everest, when you're here. So the fractional concentration doesn't change. But the total pressure changes, so the total pressure is what's changing the partial pressures.
Can you explain C again one more time quick?
Say that again?
Could you repeat C again? I didn't catch that.
Talk about C again?
Yeah, the fractional.
Yeah, the fractional concentration is the percentage of any of the gases, whether it's nitrogen, CO2, or oxygen. They're the same.
Okay.
They are completely unaffected by altitude. The fractional concentration.
Is oxygen 21?
It's 20.91.
Okay.
So let's round it up to 21%.
Okay.
Yeah. So do know that oxygen's 21%. Okay.
Did you want us to know CO2 as well?
CO2 is 0.0004. No, just think of it at close to 0%.
Okay.
Nitrogen's about 79, but do know CO2 is about 0 and oxygen's right around 21%. And that'll do you just fine. Okay. In the lung, which would help to prevent the formation of pulmonary edema, and you can kind of look up at that diagram, that illustration up on top. A drop in tissue hydrostatic pressure. So if hydrostatic pressure would drop, would that decrease the formation of edema? No, that wouldn't. No, that wouldn't. B, increased tissue osmotic pressure. Increased tissue osmotic pressure would draw more fluid to it, so that would favor edema. C, an increased concentration of plasma proteins. Proteins draw water toward them, so that would decrease. So D better be wrong. An elevated blood pressure in pulmonary capillaries, that's an increase in capillary hydrostatic pressure. That would tend to increase the chances of pulmonary edema. Man, we have a lot. Oh, we're coming up to reading here. So, in the nose, 21, normal quiet breathing. Normal quiet breathing at rest involves A, negative pressure ventilation. Yes, I agree with that. B, activation of the ventral respiratory group. No, we've already done that. Contraction of the diaphragm and internal intercostals. It's external intercostals. Can you believe that's it's external intercostals. A is the only correct response there. Moving from FRC to RV, you know, hey, flip over to the front page and look at that spirogram if you want to. Moving from FRC to RV is a result of which of the following? Inactivation of the ventral respiratory center. It'd be activation of the ventral respiratory center, wouldn't it? Alveolar pressure that is initially positive falls to zero. Well, alveolar pressure at FRC is 0. We already established that, so B and C, throw them out. I'm embarrassed that I even showed you. D, alveolar pressure that is, wow, this is very similar to what we've seen before. Alveolar pressure that is initially 0 becomes transiently positive and then returns to 0. So actually, I'm testing to see if you understand that that's a forced expiration. So actually, there was a different part to that. B is a correct response. Intrapleural pressure that is initially 0 becomes transiently positive and then returns to 0. It doesn't start at 0. It doesn't end at 0. It's negative. Otherwise, you'd have to collapse along.
So D was correct, right?
D is correct.
D is in dog.
D as in dog. D as in Dave. Yes. Okay, 23. For a person at rest at sea level, which of the following are normal pore pressures in certain compartments for oxygen and CO2? So PV, that is partial pressure of mixed venous blood. That's the blood that you'd see in the pulmonary artery. P capital A, that'd be alveolar. P little a is arterial. And before we go looking through that mess, what's the partial pressure of mixed venous, the partial pressure for oxygen in mixed venous blood? I agree, 40. What is it for partial pressure of mixed venous blood for CO2? 45. It's 150 and 0 for inspired gases. I already mentioned to you that alveolar partial pressure of oxygen is around 100. What is the alveolar partial pressure of CO2? 40. So, it turns out what's over here in pulmonary veins equilibrates in a normal healthy person, equilibrates to whatever it was here in the alveoli. So, the P little a O2 is 100, P little a CO2 is 40. Because it's going to come out, oxygen's going to come out by diffusion, and it can't get higher than what it was up there. And CO2 is going to go in by diffusion, and it can't go any lower than what is in there. So gas exchange is by partial pressure gradient. So we're looking for those in B. I think it's B. 40, 45, 140, 140. Now, we have a patient. We have a patient who, this is what you see in this patient. Let's say you see this in this patient, but this patient has a severe diffusion impairment. What's going to happen over here to the arterial blood gases? Oxygen's probably going to be below 100. To make it easy, oxygen's going to be below 100, CO2 is going to be above 40. Won't have enough time for equilibration. That's somebody who has severe diffusion impairment. And over time, this will start creeping up. And then that creeps up even more. And gets worse and worse and worse. Okay, now we're in a nephron. 24. Water does not follow sodium in which segment of the nephron? Without looking at these, give me a name. Ascending limb of the loop pendulum. Which one is that? It is segment P, or the answer B. Carbonic anhydrase. We just talked about carbonic anhydrase is high in which segments? Proximal tubule and distal tubules, M and Q, right? That's also where we have bicarb reabsorption. That's where we have proton secretion. Not surprising. Which segment has aquaporins in the Golgi that can be transferred to the luminal membrane in response to ADH? Which segment? Collecting that. How about the collecting duct? Which one's the collecting duct? R. Aldosterone-mediated sodium reabsorption occurs in segment collecting duct R. 28. Rescue breathing that is performed during cardiopulmonary resuscitation. That's going out the window with hands-only CPR. But rescue breathing that's performed during CPR by a first responder is an example of positive pressure ventilation, negative pressure ventilation. Neither. It's positive pressure ventilation. Yes?
What would be happening in N on the diagram above? What happens there?
Where? Which one?
On N.
On N? Okay, going down the descending limb of loop family, there's a lot of water reabsorption. Not as much as going across the proximal tubules, but there's a lot of water reabsorption. It's permeable for sodium chloride, but there's just no gradient for it. So if you remember, if you are filtering like 125 mils of fluid per minute, 2/3 of that is reabsorbed by the time you get to the end of M. And by the time you get to the beginning of Q, you're down to 20%. So all that reabsorption between 1/3 and 20%, well, that came out in the descending limb group at the end, as you asked about. That's where that extra Okay, I actually drew this out to begin with. Moving from FRC to total lung capacity results in a change in airflow resistance. Going from FRC to TLC, is that increasing resistance or decreasing? Decreasing. So which statement is correct? Airway diameters increase. Yes, I see enough heads going up. Septal wall radial traction decreases. It actually increases. It's pulling the airway open, pulling the airway outward. Airway resistance airflow increases. It decreases. So A is the only correct response. Okay, this number 30, we can even use that illustration up above. Renal sodium hydrogen ion countertransport activity. A, can acidify the urine. Yeah, yes, it can do that. B, it occurs at its highest rate in the collecting duct. It's in the proximal tubule and the distal tubule. C, it's important for bicarb reabsorption. Absolutely. Bicarb's freely filterable, and we need that proton to convert it to carbonic anhydrate, to carbonic acid. It dissociates to CO2 and water, and those can be absorbed. 31. Oh, I love this one. Actually, I don't really need to draw anything, but I'm going to draw an oxyhemoglobin dissociation curve. It looks something like that. So this is percent oxyhemoglobin, and this is partial pressure of oxygen. So the higher the oxygen environment, the more of the hemoglobin will be in the oxyhemoglobin form rather than the deoxyhemoglobin form. Compared to arterial blood, the oxyhemoglobin dissociation curve for capillary blood in working skeletal muscle is so. In working skeletal muscle, what am I getting at there? It's going to be a high metabolic activity, so is it going to be pumping out CO2 or picking up CO2? CO2 is going to be coming out of working muscle, right? Does working muscle have a higher temp or a lower temp than non-working? It's a higher temp. Working muscle, do you think it can be generating hydrogen ions? Yeah. What do all those do? An increase in CO2, an increase in temperature, an increase in hydrogen ion concentration. What do they do to this line? A downward right shift. A downward right shift. So the capillary blood in working skeletal muscle, I would expect it to see downward to the right, B. You understand why that's the case. Okay.
No. Like, I got that answer, but I don't know exactly why I got the answer.
Okay, so anytime, so here is the regular oxygen-dependent oxyhemoglobin dissociation curve. An elevation in CO2 will cause a right downward shift. An increase in temperature will cause a right downward shift. An increase in hydrogen ion concentration, or the other way of saying that, a lower pH, causes a right downward shift. Ask yourself, does this make sense? If we would draw a line through any point here, when you have high CO2, high temperature, and increased proton production, that means that tissue is metabolically active. So ask yourself, would you want hemoglobin to hold on to its oxygen or release oxygen here because it's metabolically active? So luckily, we're built, hemoglobin is a really smart molecule. It knows when to hold on to oxygen, and more importantly, it knows when to let it go. It's smart. And the more metabolically active a tissue is, the more you're going to have this in the capillary blood, and the greater the tendency to release there. Does that fit a little bit better now? As one relaxes, and no air is moving in and around the lungs. One is at her D, functional residual capacity. We've hit that. 33. Let's see how many more we want to do with these things. I did want to get through 34 and 35, most assuredly. So, 33. Somebody's doing a forced expiration. Forced expiration. A, phrenic nerves activated. Right off the bat, that's wrong. That's for inspiration. So A's already gone. B, dorsal respiratory center activates. Boom, that's already gone. It's the ventral for forced expiration. C, internal intercostals contract. Okay, okay. Thoracic cavity volume decreases. Okay. Alveolar volume decreases. Okay. Alveolar volume pressure increases. Okay, air exit C is right. Let's see why D has to be wrong. D, ventral respiratory centers activate. That's true. Intrapleural pressure decreases, intrapleural pressure increases. So from that point on, well, you know, these other ones might be right, but that's what tosses that one. I don't know if they're right or wrong. I just stopped right there. E, abdominal muscles contract. This is correct. Thoracic cavity volume decreases. Yeah. Because when the abdominal muscles contract, it's pushing that diaphragm up into the thoracic cavity. Thoracic cavity volume is going to decrease. Intrapleural pressure increases. Oh, this is looking interesting. Alveolar pressure decreases. Oh, that's a tough one. It tried so hard, and it just couldn't hang. It just couldn't. So, now, I realize for 34 and 35, you haven't done these yet, but I want you to conceptually look at and think these through. So here I have an afferent arterial. Here's what I try to represent as glomerular capillaries, don't I? Efferent arterial. Here is my Bowman's capsule, so this is the glomerulus. Okay. So here we have a person with an inulin, and notice that this does not say insulin. The clearance of inulin. Clearance of inulin is used clinically as a measure of glomerular filtration rate. So this person has an inulin clearance of 100 mils per minute. So what this is saying right here is that 100 mils is coming across every minute. Okay? They have a clearance of para-aminohippuric acid, PAH, a lot easier to say that, of 500 mils, oops, excuse me, 600, no, this one's 500. I have to put my hand on it. 500 mils per minute. This is their renal plasma flow. So this means that every minute 500 mils of plasma is going to come up through here. 100 mils of that ultrafiltrated plasma is going to come across, so that means only 400 is going to be coming out right there. Okay? So these are renal function tests that have been done to look at how a certain part of this kidney is working. And I think this comes up later, so I'll just kind of finish filling this up. What is this person's filtered load for? And they have a glucose concentration of 80 milligrams of glucose in every 100 mils of plasma. So what is this person's filtered load of glucose? And filtered load, you're just going to see, is just glucose is freely filterable. So you just look at, okay, filtered load is how many milligrams is coming across every minute. So we look at, this person has 80 milligrams in every 100 mils of plasma, and every minute their GFR is 100 mils per minute. These cancel out. Every minute, 80 milligrams of glucose is coming into the nephron every minute.
So if it was like 150, it would only be 100? Like of glucose? Because you can only filter 100?
If what's 100?
If like your glucose level or so.
Their plasma glucose?
Yeah.
If their plasma glucose is 150 milligrams per 100 mils, then 100 mils of filtrate is going to contain 150, so 150 milligrams would come across. See, there's 100 mils coming across every minute, okay? And you have this much. Glucose is freely filterable, so if 100 milliliters comes across every minute, it's going to carry with it 150.
Will you explain the PAH one more time? I think I got confused.
PAH is, this is how much plasma, it's your effective renal plasma flow every minute that's coming up through here.
So
Read that chart, read those, and it'll get a lot easier.
Okay.
If you had a reduced RPF, then that would change the,
If you have a reduced GFR,
well,
that would reduce the filtered load.
okay.
Yeah. I think you'll see that. I think you'll see that when you go through that. I did want to get to this other one in 35. So here we have a slightly different situation. Their creatinine clearance. Creatinine isn't a great, you're going to see in courses to come, and I even spelled it right, this is creatinine. Creatinine is used to measure GFR. It has limitations, but it's still used somewhat. In this case, the person has a glomerular filtration rate of 150, and this person's clearance of PAH is 600, so every minute, let me get rid of this stuff, every minute there's 600 mils of plasma coming across, so that means 400 mils are going to be able to go on that way, okay? And this person is taking an antibiotic. This person, she's taking an antibiotic, and it has a clearance of 350 mils per minute, the clearance of the substance. And it says that this antibiotic is freely filterable. It does not undergo tubular reabsorption or metabolism. what's correct. So, this I just want to see if it just makes sense to you without knowing anything else. So, it's freely filterable, so clearance is mils cleared per minute. So you can clear out 150 mils of solution containing that antibiotic just by glomerular filtration. But what's coming out here? 350 milliliters is being cleared every minute. So if glomerular filtration can only take care of 150 mils of that, where's the other 250 mils coming from? Clearance coming from? Pardon me? Secretion. Good, very good. So you don't know where, but 250 mils of plasma is being cleared of this substance by tubular secretion. So in this case, whenever your clearance is greater for a freely filterable substance is greater than the GFR, that means some of it has to be getting in via tubular secretion. So 150 mils, yep, GFR can handle that. Tubular secretion must be handling 250 to give, 200, sorry about that. 200 to get you to the 250, 350, whatever. Okay, let's finish out this page, and there seems like there's something on the next page that I wanted to talk about. Okay, we already looked at 36, premature infants who lack pulmonary circulation.
What was that?
The correct response there is A, more antibiotic is being cleared by tubular secretion than with glomerular filtration. Sorry about that. So 36, we've already hit this. Premature infants who lack sufficient pulmonary surfactant have A, increased elastic recoil, that's true. Decreased pulmonary compliance, that's true. Increased work of breathing, that's true. D is the correct response. This one we haven't talked about yet. When I can use the same illustration because the graph looks very similar. When you have an increase in cardiac output or an increase in pulmonary artery blood pressure, what happens to pulmonary vascular resistance? They go down, it goes down. So when cardiac output, pulmonary artery blood pressure increase, pulmonary vascular resistance increases and decreases. Pulmonary capillary filtration force decrease, that'd be an increase because that's capillary hydrostatic pressure. The surface area for diffusion